we'll be continuing with the next presentation on glaucoma. That is the use of spectralis in diagnosing glaucoma. So while we're doing glaucoma screening, these are the basic things that we do. One is HVF, Humphrey visual field, then OCT, RNFL, GCC, fundus photo, and lastly CCT. So with this spectralis machine, what advantage we are getting? Let's see. Start with the multicolor fundus picture. These are excellent photography of fundus where there is a multicolor picture, as well as there are a few other modes like blue reflectance, green reflectance, and infrared photographies. So these are normal fundus photograph where you can see, and this is the glaucoma. In a case of glaucoma, where you can see the inferotemporal defect. This area, it's not very clear here. This is the area where there is a nerve fiber layer defect, and in the blue reflectance, if you can see, this is the area, this dark area is the area where the nerve fiber has been lost. Hello, 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 hello. So now, again, this picture, there is a nerve fiber layer defect here, which is here, and corresponding with the blue reflectance. The blue reflectance is the mode which shows us the defect in the superficial layer of the retina. There is a nerve fiber layer area, and very nicely you can see it here. And one of the most important thing in glaucoma is to correlate the test report. So when we find a defect like this, we must ensure that this is in coordination with the visual field report. Here you can see the inferior nerve fiber layer defect in the inferior arcade is tallying with the superior defect in the visual field, which is what we expect. So the correlation is perfect. The retinal topographical correlation is a must that we must do in glaucoma. And here also the same thing we are finding. Here the superior arcade defect. Here you can see this area, the color code. From the color code we can make out that there is a thinning, and here corresponding inferior visual field defect is seen. So now this is the most important thing of this machine, that is a glaucoma module. It's a separate glaucoma module that asks us to look into 3 areas. You can see the rim area, which is one, the optic nerve head area. Then you can see the RNFL area, which is inferior RNFL, and then comes the ganglion cell complex area, which is area 3. This is how spectralis guides us to go into the diagnosis. Now you see there is a color code. There is a color coding of the posterior pole. You can see in the glaucoma module there 1, 2, 3, and in the color code, if you just give some emphasis on this, this is like imagine this is kind of this area. It's like a big glacier coming out coming from down from a mountain, and this blue area, if you imagine it as a river, this river is being created from the glacier because of the melting of ice. If you think that way, then it becomes very clear to you that there is a dissimilarity between the superior and inferior part here. The blue area is they are seen in the inferior RNFL area, but in the superior it's not there. So the glacial lake is melting and a river is appearing, which is coming straight down from the mountain. And this is what the first thing in glaucoma happens. Either in the superior or inferior arcade, preferably in the inferior arcade, we start noticing the defect. And here, this is the ganglion cell layer. You see this is a red color, means it's a very thick here. And this color code, that's how it represents. There is a notch here, you can see this notch is appearing because at this area the nerve fiber layer is deficient. So the river is coming down from the mountain, there is melting of glacier lake. Also this area, the melting is very prominent, which gives a classic picture of a shell of a snail. You can see the notch here. So this is the thing that we should focus in glaucoma, and spectralis very nicely delineates that. The second advantage of spectralis is the MRW analysis. This is a minimum rim width analysis. This is a very unique thing. The minimum rim width defect has to be there in glaucoma as per the the guidelines. What is that? Minimum rim width is the distance between the Brooks membrane layer and the internal limiting membrane. Here you can see the Brooks membrane is terminating here, and this is the internal limiting membrane. So this gap, this is a distance. If it's low, very not under the normal calculations, here you can see this is the area which is the norm seen among normal population, and the red area is where the danger zone lies. So if that thickness comes down into the red area, then it denotes there is a thinning of minimum rim width, MRW, that we see. So there is a defect in MRW suggestive of glaucoma, and it is very nicely shown in this machine. Here you can see there are so many modes to show it. Here also the several nasal and temporal inferior thinning is noted. One important thing about MRW is that the MRW and RNFL both has to be abnormal in glaucoma. That is the guideline. And if MRW is normal and there is a defect in the RNFL, that goes against something else which is not due to glaucoma. And if MRW is abnormal and RNFL is normal, then it goes to suggest towards some physiological problem in the nerve head and in the rim. So this is a basic gross guideline, but it is not that 100% it is every time we see like that, but it is overall guideline in glaucoma. So this is the glaucoma overview analysis. This is a very important thing, that first thing we look for in diagnosis. This is, see this area, this is the MRW analysis which shows the red area, as you all know, is defective. This is the RNFL area and this is the ganglion cell layer. You can see that shell of a snail is here. You can see the notch, you can see the river, you see the melting glacier, and the corresponding this shows the hemispheric asymmetry, which whether both hemispheres are normal or not. So this is another guideline, but we follow this 1, 2 and 3. Just focus on this 1, 2, 3 in glaucoma diagnosis. All these 3 areas has to be abnormal. 1, 2 and 3, all 3. This is the suggestion in Spectralis glaucoma module, that it has to be a 3-zone defect, not isolated one. If there is a MRW defect, RNFL is normal, then it goes against glaucoma. So all 3 has to be defective. Now comes the biggest challenge. So is it glaucoma or is it something else which looks like glaucoma? Is it glaucomatous optic neuropathy, GON or NGON? This is the challenge that we face. It is not just that whether it's normal or glaucomatous. It's not like that. It's normal, glaucomatous or non-glaucomatous. We have 3 options to diagnose from. Because as you know, glaucoma is very poorly diagnosed disease. Around 50 to 90% glaucoma cases are diagnosed, and on the contrary, 50% glaucoma patients are overtreated. They don't have glaucoma, but they receive medicines. So it's of utmost importance to us to isolate and confirm that this is glaucoma. Then we should start medicines, because medicines also have their own drawbacks. So we must question ourselves, does it fit the model of glaucoma? If not, then what? So there are few common masqueraders of glaucoma, which these guys, they look like glaucoma, but they are not glaucoma. And several of these kind of patients, they receive glaucoma therapy for years. First is most common is myopia. Myopia is very common. Then comes AIO, anterior ischemic optic neuropathy. Then comes multiple sclerosis, which is a demyelinating disease causing optic nerve head changes which look similar to glaucoma. Then come CVA, cerebrovascular accidents. They also give rise to hemianopias and optic nerve pallor, which is can be mistaken for glaucoma. Then we have a few optic neuropathies like autosomal dominant optic neuropathies, Leber hereditary optic neuropathies. These are the common masqueraders. That all these they affect the optic nerve head, but as similar to glaucoma, but they are not glaucoma, and we must isolate them separately. Lastly, macular scar or any scar around the macula which can give rise to a defect, which will be picked up by the machine as something like glaucoma. Here in this picture you can see there is just only one zone defect. There is a single hit in the middle, that is RNFL is defective, but the other 2 parameters are normal. So this is not glaucoma. Again, in the right eye also you see the same thing. You see can see in the GCL there is no defect, there is no river and there is no melting of the glacier. And myopia, the most common masquerader, you see there are two zone defect here. So very reflexly there is a tendency to diagnose this as glaucoma, but you can look at the rest of the thing. This pink color code, the generalized thinning of the retina, which is very unlikely in glaucoma in the early or mid stage. So these are the common clues. The next clue is you have to correlate with the fundus picture. You see the optic nerve head picture. You see a crescent, two big crescents around the optic nerve head. This is suggestive of myopia. Now comes another masquerader, which is CVA, a stroke in the brain. This here you can see very rightfully all the three, there has been three hits, 1, 2, 3, all cross. These areas have been affected, but now comes another clue. This is the defect is here. It's a vertical defect. It is not obeying the horizontal midline, which in case of glaucoma happens. It's obeying the vertical midline. So this defect is homonymous hemianopia, right-sided. This is due to brain stroke and causing defect because of involvement of optic tract or optic radiation. So these are the common things. In any case, you can see and you see that the three zone defect. So why not this is a glaucoma? So it is not like that. If the three zone defect means glaucoma. So there are other parameters, other pictures in the machine that guides you towards something else. Now here is a old BRVO scar. You can see this is very dissimilar thing that we see in glaucoma. This is a patchy defect here. A patch, there is a patch here which is defective, but the rest of the things are normal. Here you see there is a defect in GCL. Here there is some thinning in the RNFL, but MRW you see it's perfectly normal. When you see a perfectly normal, always doubt the diagnosis of glaucoma. That's why MRW is so important. In the same patient there is a macular scar. You can see this scar is giving rise to a defect, and that area affected is very close to the superior inferior arcades, so it can be mistaken as glaucoma. Another mode in this machine is RNFL analysis, TSNIT curve, which is common in others also. And this is something interesting. There, the TSNIT asymmetry has to be established. Here you see there is a similar defect, which is this is the TSNIT curve. In both eyes they are following each other, but here you can see this is a glaucomatous defect. This curve is not following each other. This is lagging behind. And here you see this is a left eye curve which shows a defect here. So while differentiating, particularly important because myopia has, several times we face the challenge to differentiate myopia. So then this TSNIT asymmetry comes in very handy. So there are several modes that we have to look for. Then the posterior pole analysis, which again gives us the confidence to diagnose it as glaucoma. As you can see in this picture, the river is so big and there is huge melting of the glacier. Next, another interesting thing comes the Hood report. The Hood, normally we have a glaucoma overview report, and Hood report is something, it has been introduced by Dr. Hood, who thought that we must address glaucoma problem separately, we must look at the pictures differently. So instead of TSNIT curve, he introduced the NSTIN curve. So in TSNIT, these temporal areas were sideways, but here he brought it in the middle. And glaucoma defects are usually in the temporo-inferior and temporo-superior. So whenever we look at this, we first look at this area, whether this is defective or not, Instead of previously the NSTIN curve, this defect used to appear here or here, which there was a chance of missing it very frequently. So NSTIN curve is very important. The Hood report combines so many things together. It's a perfect picture of, it's a just representation of so many findings. Here you see the RNFL, this is common in everything, all the other machines. This RFNL thinning you can see. All the things can be seen in a same picture. These RNFL thinning, you can correlate this RNFL thinning with this picture. Here you can see the temporo-inferior RNFL thinning from this NSTIN curve. Here in the GCL thinning you can correlate. And one interesting thing is that there is a visual field. This is the portrait that what kind of field defect you expect in such a case. So that is also projected. This is the expected visual field defect. This 24-2 and this 10-2. Expected visual field defect is here, as the defect is inferiorly, so expected visual field defect will be superiorly. And now you match these two. The same superior field defect is being shown here that the Hood report had projected. So it's a perfect report for quickly getting lot of information from a single picture. Now the correlate the left eye picture. Here you also see in the same patient, the Hood report shows this, and it projects that visual field defect will appear here. You can see the same thing. So these are the comparison between glaucoma overview and Hood report that we very frequent. If we get this together, we get all the information, so nothing will be missed. And another interesting thing is that when in the early stages there is a doubt that it may not be glaucoma, then we have this OCT angiography on top of everything. This OCT angiography is this around the optic nerve head. It shows the defect. Can you see this dark area? This in glaucoma, this peripapillary vessel defect appears here. So OCT angiography in Spectralis also highlights, yes, there is a defect. If you have a suspected defect, you are missing it frequently because this need not be done regularly. But if there is in an early stage, there is a problem that there can have a defect, but you are not getting it into it, you can go for this OCT angiography also. So area of the vascular defect will correlate with the glaucomatous problem. Now this is the doubt, is this a glaucomatous defect? These two are normal, and this is there is a defect, but this is not glaucomatous because this is only one area of defect you are seeing. This is a picture of non-glaucomatous defect that we can clearly understand, isolate from this, because you see the defect is here, the rest of the two is here. In a traditional OCT machine, you get only one picture, you see RNFL defect, you categorize it as glaucoma, but here you can see there are so many suggestions from everywhere. As you see, you can compare this glaucoma assessment again, as there is a whether these things are present or not. And lastly, this is the picture where these are the basic theory that how you differentiate glaucoma with non-glaucomatous defect. In glaucoma, you go for the visual acuity deterioration is not that marked like in case of non-glaucomatous. The color vision is also not that much affected in glaucoma, unlike non-glaucomatous defect. And these are the few salient features that in glaucomatous defect you expect a slow deterioration of visual acuity, but in non-glaucomatous, like in any neuropathy, there is a sudden deterioration. The onset is very sudden. So these are the few points that in keeping in the back of your mind, this is the machine that guides us in diagnosing glaucoma and helping us to not to overtreat. Finally, technology alone is not enough. It's the doctor, the clinician who has to take the last call of diagnosing glaucoma. Thank you.